Thank you. So I'm Yuda Handelsman, and I'm actually the treasurer of both the American College of Endocrinology and the American Association of Clinical Endocrinologists. And I was put the task to put this program together, and I want to share with you a couple of the issues that we had looked at. So we looked at a disease state or a condition state because it's not truly defined as a disease by itself, and to see is it dangerous, as you heard just from Dr. Garber. And for that, the questions were formulated have responsible chairs for them. And with your permission, I'd like to introduce the ones that at least are here. The question number one, which was looking to see how to define this whole condition, was chaired by both Dr. Garber and Dr. Einhorn, with the help of a specially important session where we look at pediatrics and adolescents, and Dr. Ken Jones here, who is from Professor of Pediatrics in San Diego, who has helped us looking at a very important group of people where that risk is starting to emerge there, and see how much that can be contributed to that issue. The question number two, which we felt was very important, everybody was looking at preventing diabetes, and there are several consensuses. How do we prevent this terrible disease called diabetes? But when we look at this group with early hyperglycemia, and we say, well, they're not really diabetes, but what will happen to them? Should we ignore them? Do they have something going on? And how far will their complication go? This particular group was chaired by both doctors Paul Jellinger, who is a clinical professor of medicine from Miami, and then Dr. Harold Leibovich, who is a professor of medicine from downstate New York. Am I correct, Harold? Mm-hmm. Thank you. Question number three, as you heard, was the thrust of the question. Are there any interventions in this group that can change their outcome? And in that particular question, we assembled, as part of our experts, group of people internationally who has done work within this group of patients and presented to us what they focused on, whether it was focusing on lifestyle management, which we believe is the most important part of the approach to treat this group of patients, and then in the high-risk group, looking also at various medications that can be done. This particular session was chaired by Dr. Ed Horton, who is professor of medicine, I believe, in Harvard Medical School, and he's chief clinical researcher at Joslin. Is that the correct? He is in charge on a lot of research over the years, and Ed Horton's knowledge is very important. All the people, by the way, on here are experts in their field and in various clinical trials and various approaches to this group of people. In particular, Dr. Horton is one of the investigators of the diabetes prevention program, for example, and a lot of information that he could bring to the table to us discussing. And I co-chaired that particular question with him. It was very complicated because we examined many medications and many trials in this particular session. The next question that came up, maybe I just want to point out that when we look at the management of this group, we all agreed, therefore, that lifestyle is the first way to go. And we have to persist with lifestyle because nothing else matches lifestyle in reversing all the complication. Yet we also recognize that a high-risk group of those patients, lifestyle will not be enough to stop them from progressing to diabetes. And therefore, we looked at medications and trials that were done, and we approved accordingly based on the strength of the trial and the patient benefited from there. But there was also consensus that we have to reduce the risk of cardiovascular disease in this particular group of patients, as well as microvascular. Namely, we look to treat at the lipid levels, whether cholesterol, dyslipidemia, and low good cholesterol, whether to look at the blood pressure, whether look at aspects that can lead into cardiovascular disease. And so we came up with a very strong message. And some of the people on our committee, like Dr. Richard Nestor from From Harvard too? From the Lay Clinic, who is a cardiologist, which endorsed part of our discussions. Question number 4 was looking, as you heard, at how to monitor these patients, how to predict who will convert. Was chaired by Dr. George Gunberger, who is here, who is also a professor of medicine. Which university? Wayne State University in Michigan. And he was co-chaired with Dr. Eti Mugisi from Los Angeles, who is the Associate Clinical Professor of Medicine from UCLA. Question number 5, looking at the costs, was chaired by Dr. Don Bergman, and the chief person on the committee responding to that was Dr. Tim Garver, who is a Clinical Professor of Medicine from Alabama. And lastly, the future research that we thought was a very critical part of the discussion was chaired by Doctors Phil Levy, who is a Clinical Professor of Medicine from Arizona University, and Dr. Jim Gavin, who is a Professor of Medicine from Emory University. I think that would conclude my part, and obviously we all can help in answering questions, and Dr. Dane Heinemann will conclude his section of the discussion.
And just before opening to questions, I think it's very important to be thinking about the lessons we learn about how we understand diseases in general, especially diseases that are a continuous variable, such as glucose, which goes from perfectly normal to frank diabetes, with the stage in between that we're just learning to understand. And I know we get hung up on labels, and we get hung up on specific numbers, whether it's for blood pressure, for cholesterol, or for sugar. But I think it's very important that our work in the last few days, and really our understanding as clinicians, teaches us that these cut points really are arbitrary, and we should be less looking for numbers than really people at risk for medical problems from specific combinations of issues, a little bit of blood sugar, a little bit of cholesterol, a little bit of blood pressure, and all these together. So it's people and the evaluation of people that we very much need to be looking at. But looking at this group that we're calling prediabetes, we don't mean to be creating a brand new illness. It's really to bring attention to this gap, the word that Dr. Garber used, which I think is a correct issue. There's a gap between what we understand as fully normal and clearly disease. And interestingly, as we examine these patients at this population, there clearly was a group that were the most severe, that were almost indistinguishable from people with type 2 diabetes. It's just they hadn't been labeled as type 2. They didn't consider themselves type 2 because they didn't meet this arbitrary cut point. Again, I think the word arbitrary is important. Arbitrary doesn't mean it was capricious. It just means that the cut point for deciding when diabetes begins could have been other than the number 126. There was very good data to make that number somewhat lower than that. So we're trying to really not get hung up on these arbitrary measures and try to really be understanding the continuum of disease, especially in areas like type 2 diabetes, hypertension, cholesterol, etc. So I think with that, if there are any other statements that members of the committee, the chairs, want to make? Okay, so I guess,
yeah.
yes.
If I may make one.
Absolutely, Dr. Lebowitz.
If you could step to the podium.
Yeah,
You need to use the mic, you know that.
Albert,
Yeah,
Okay.